Hospitals Trust. And I've been working over the last few years quite close with the critical care department with this initiative, and with various other of my colleagues who are all here. I don't know if anyone fancies putting a hand up, anyone that works in critical care. So really our work started about 3 years ago now, when there was a patient on critical care who very sadly had completely intractable epilepsy. This couldn't be reversed. She was unconscious, intubated, ventilated in critical care, and she was going to die. The decision was made that we would have to withdraw care because she couldn't survive. Now, this lady's partner was a GP, and her partner asked us, is there any way this could be done in her own home? And obviously at first that seemed like quite a sort of scary proposition, but I guess the ITU consultant who's involved and who's really been the sort of main instigator of this project, Dr. Ian Carrasco, he was really keen to help, and he involved our palliative care team. And as with any of you who've worked with palliative care teams, we always try really hard to try and achieve patients' wishes as best we can. And we managed to achieve it, but very much on an ad hoc thing. We sort of spoke to the GP concerned and had to deal with the ambulance service and through the various hospital teams. And we did manage to send this patient home, and her care was withdrawn in her own home, and she died there shortly after. And the feedback was amazing from that family. It meant an awful lot to them that this lady had been in her own bed in a comfortable surrounding and not in the very clinical environment. I don't know if everybody here has ever been into an intensive care department. I know I less so now, but I still find it quite a scary environment. It's so, I don't know, it's so big and it's so weird, and the patients look so strange with their tubes in, and I find it quite frightening. So I think, I can totally see why this is, seems desirable, but it is complicated. So Dr. Carrasco was the main person to kind of really put the initial work in, and he did a huge literature review and discovered there are a few other places around the world, but not many that have done this on a regular basis. There are sort of case reports written up, but no sort of large numbers of patients doing this. Although it's more common in children, which I suppose is maybe not surprising. But it does happen in the UK with children quite a bit, I think. So having done that, we sort of had to look at the costs, and is this something that was viable? And yes, he worked out that it is, as long as you move fairly quickly. Because when you decide to withdraw care, obviously every day is money on the unit, and if we're then delaying that a lot, that's not beneficial. But we realised that if we can move quite quickly and sort of get them home within 24, 48 hours, then it was cost effective. We gave a lot of thought, obviously to the ethics of this, and we involved as many different people as we could, all the different stakeholders. So obviously the hospital staff, but we also involved local GPs, district nurses, the hospice. So our local hospice, St Francis Hospice in Havering, and they have a hospice at home team and a community palliative care team, and they've been enormously supportive through this process. They were very, very keen to help us, and they've been giving us a lot of advice and support. And then we looked at our, so we have a individualised end-of-life care plan, and we looked at how we could change that document to make it more appropriate for this, because with documentation, there's quite a lot we want to document, partly for sort of clinical reasons, but also partly for sort of creating an audit trail, because when we do this, we want to be able to look back and see, how did it work. So we sort of individualised. We sort of made sort of altered slightly our individualised end-of-life care plan and created one especially for use in critical care, and that's now used in critical care for all deaths in critical care. Well, as many as possible deaths on critical care, and it can also be used for these patients who are withdrawn at home. So there've been, a lot of benefits to this. I think so. Since it's obviously quite a short time since that first case, and it's it's been a slow and arduous process, really going through particularly sort of bureaucratic hoops within the trust, really. It's all all sort of for safety reasons, etc. But it's been a long journey. We've since then, we've managed to, one more patient has had withdrawal of critical care at home, and that went well. There are a few hiccups, but ultimately it went smoothly. We've also discharged a couple of other patients directly from critical care to home. So they weren't patients who were having life support, but they were still on critical care. And I think something that we really recognised is that critical care don't discharge patients home. So to the nursing staff there, this was totally new, and they didn't really have experience in that environment of discharging patients home. So that's something that we've worked really closely with the nursing staff, and now we're able to, when appropriate, instead of transferring patients into the ward, and then then there's a whole other team involved and other sort of more delays. We're just managing to keep things a bit more fluid. I think, to be honest, the best thing that's come out of this is it's massively improved our working relationship with the critical care department. So we're now familiar faces. We go down, trying to go on a weekly basis to each of their units, that started because we wanted to try and identify patients who might be suitable for withdrawal at home, because we realised because we need to move quickly, we want to know about them as soon as possible, and maybe before the decision's been made, but we can start discussing it and thinking, would this be realistic? Would this be something they might be interested in? And although we haven't found many patients that's been the right thing for, actually what we have found is other patients who need us and who benefit from our palliative care team support. So that's been, I think, a huge benefit from this piece of work. And I think end-of-life care in general I think it's improved within critical care. I think it's increased awareness. It's now something that people talk about more often. Obviously the end-of-life care plan is being used now. So I think the things that we found difficult have been, so there is a big department, we're a big trust, there are a lot of consultants, and I think that sort of getting everybody to know about our work and to sort of feel that it's a good idea, and that's ongoing really. But there, many of the doctors now, are sort of very happy to work with us on this. Identifying patients at an early enough stage, that was something that was tricky, as I've mentioned already. Getting the support of the GPs and district nurses was, they definitely were really interested in our work, but of course everybody's really stretched, and I think that a massive anxiety was, would this create a lot more work and unmanageable workload for the community healthcare professionals? And I think that we've managed to adjust our plans, we've talked to them, we've listened, and it's been very much a to and fro process. I think one of the big sticking points with the GPs in particular was around what would happen after the patient dies, because of course they won't have seen them, or they may not have time to come and visit them, which creates complications with the death certificates and things like that. But having listened to our colleagues and thought about it, we've now just agreed that the palliative care consultants will do all of those certificates. So we're listening and responding, and it's an ongoing thing, it continues to evolve. So plans for the future is we really want to continue our work with critical care, and actually this week, on Wednesday, so yesterday was the first critical care MDT that involved palliative care. So one of my colleagues went along to that, and I haven't actually heard back how that went, but I'm sure it was a success, and hopefully that's now going to be a regular thing. So we'll be working more closely all the time. So our trust sends out a bereavement survey routinely, but of course these patients aren't actually dying in hospital, so they sort of potentially might miss that. And also there are specific tools that are used, so bereavement surveys used for critical care patients. So what we want to do is look at those and actually sort of create our own specific critical care bereavement tool that we can use on the unit and at home. And we're still working on some information leaflets for patients and families. Of course, most of the time it's the families that we'll be dealing with about this, and that's something that's still ongoing. But all in all, we are feeling really pleased with what we've achieved, and need to keep the momentum going. But I think this today is definitely going to really help us refocus the mind, and it's so lovely to realise that other people think this is good work and it's worthwhile work, so that's really encouraging. Thank you.